Good afternoon, everyone. Thank you for joining us.
Sabrina, I'll show this. We have to show this later. Sabina,
I'm not sure who's sharing. 1 second. Okay.
Okay. Welcome to our annual meeting. We have two days, 2 afternoons, today and tomorrow, from 12 to 3. And our network, if you're not talking, could you mute your phone or microphone? We're a collaboration involving 12 universities across 6 states, from Alaska, Idaho, Montana, Nevada, New Mexico, and Wyoming. And today and tomorrow afternoon, we're going to have presentation by our pilot grantees, the 8-year grantees, including 1 previous grantee. And now I want to introduce our keynote speaker. Our keynote speaker is Dr. Curie. He's the Senior Vice President and Chief Medical Officer of Aetna. Before joining the CVS Health, Dr. Rhee was working at the IBM Watson Health for 10 years as Vice President and Chief Medical Officer. And he oversees the health of global workforce of IBM in 170 countries. Before joining IBM and CVS Health, Dr. Rhee worked in the federal government. We worked together at NIH, and also he later worked at the Health Resource Service Administration. Dr. Rhee got his MD from University of Southern California School of Medicine, and his Master of Health Care Policy from Harvard, and Bachelor of Science in Molecular Biology and Biochemistry from Yale University. He has training in pediatrics and internal medicine from Cedars-Sinai Medical Center in LA. So today he'll talk about mission, health equity. Dr. Rhee.
Thank you, Dr. C. And thanks to all of you for welcoming me for this opportunity to talk with you. I'm happy to, in the chat function, if you wanted to ask questions while I'm presenting, I'm happy to do that. I'm just want to make sure, Francisco, it's about 30 to 40 minutes, right? Correct?
Yes.
Okay,
yep.
All right.
Perfect. 40 minutes.
I'm going to share my screen. So just make sure you can see my screen. Can you see it?
Yes.
Yes. Okay.
Perfect. All right. I just look. I'm in this time of the pandemic and clearly with Omicron. And I was just on a prior meeting. We're looking at we currently at CVS Health do about 500,000 vaccinations a day, approximately, as we're vaccinating communities all across our country. We're also preparing for the testing guidance as it relates to clearly doing our best to provide testing availability, rapid testing, and other testing at our sites. We have about 10,000 sites across the country. 70% of Americans are within 3 miles of a CVS, and about 90% of Americans are within 10 miles of a CVS. But we also believe during this pandemic, there's been a significant acceleration of telehealth and virtual care. And there's so many things we believe will change not only during this pandemic, but beyond, as it relates to telehealth and virtual care, and even as we're seeing and experiencing today, virtual meetings. So what I'm going to talk about is just Dr. C wanted me to talk a little bit about kind of my unique career and the different experiences or learnings that I've had throughout it. If I were to simplify kind of my career, it's I started with all that training and education, 4 years of residency, 4 years of med school, and 2 years of graduate school. I went into clinical practice and delivered care in underserved populations in DC and Baltimore, and was a primary care physician, National Health Service Corps, and a chief medical officer in those federally qualified health centers, which I think are in many ways the underpinning of our health system, especially in terms of how they deliver care for nearly 30 to 40 million individuals, 95% of whom are below the poverty line. And then the second part of my career, I had the honor of working with Dr. C in the federal government at the National Institutes of Health and the Health Resources and Services Administration, and was really there at a unique time during the period of the Recovery Act, where there was additional funding for initiatives around health disparities and health equity, more investments in community-based participatory research, and significant investments, if you look at the Affordable Care Act, in looking at ways to cover many folks who are uninsured and low income and health disparity populations. So had the good fortune of working with Dr. C, Dr. Ruffin, who's the head of the National Center for Minority Health and Health Disparities. It used to be a center at that time. And then worked for Dr. Mary Wakefield as the chief medical officer for HRSA, an agency that serves nearly 90 million Americans across the country, including the community health centers that I was fortunate to serve in. Then the last decade, before joining CVS Health about a year ago, I was at IBM looking at health tech and looking more at global public health. So I'm going to try to provide a perspective. The majority of my career has been in those three segments: primary care, public health, governmental public health, and health tech, and provide some insights. I will say that the work you're doing in translational research, the ability to translate science to practice, as we've discovered during this pandemic, to speed that up is incredibly important. And I think it's a key component of really transforming what typically takes 17 years to, as we've discovered with clinical trials and vaccines, to months, to 6 months. And so our work in advancing health equity must look to translate that research into practice quickly. So look, I think all of us recognize during this pandemic, and I have a quote behind me from Brene Brown, we are in what I would call a vulnerability moment across the country and across the globe. It was 1918 when there was a global pandemic of this significant size in terms of the impact that it's had on people. And clearly the world has changed significantly in those 102, 3 years. And we're now in year two, ending the year two of this pandemic. And I would suggest that personally and professionally, it challenges many paradigms that we've had. But these are some pictures. And to me, it's been a bit of a blessing. I was traveling probably 80% of the time for IBM, global travel. And as the pandemic fell, travel was ceased. And I had more time with the family. And candidly, that played a significant role in my decision to move to CVS from IBM. I was very happy at IBM, but this idea of being able to be more domestically focused and work from home was exciting. And I do believe the issues of burnout, vicarious traumatization, compassion fatigue, these are incredibly significant amongst many folks who are on the front lines and experiencing this pandemic. But I do think networks like this and family networks are so important. And I do think in some ways Zoom and WebExes have helped support this further. Because I know, like, for example, high school friends that I used to have and used to have to see at the reunion, now we have a Zoom call every couple of weeks to a month. And just had one last night as we watched the national championship game, the college football national championship game. So in some ways, virtual can also connect us more. But the strength for serving is really important. When I started right out of residency, after all that training and education, graduate and residency, I got this job right at the corner, 14th and Irving, Unity Healthcare, as a primary care physician, as a National Health Service Corps scholar. And I recall very much then my excitement and passion for community health. And I know as I look at the projects that each of you are working on projects that clearly connect you to the community, community stakeholders, real world evidence and real world relationships there in the community. And at the time, I felt very appreciative of that network that was right around there, the schools, the community-based organizations, the research, as I would discover, George Washington University or Georgetown University and Howard University. And then across the street was a CVS. And I have to admit, at the time, I wasn't as much thinking about the role that CVS Health had in public health and in care delivery. But I did appreciate the fact that when I prescribe medications and treatments, that typically people I tell them to go across the street to the CVS. And I think if there's ever a moment we can see the value of stores like CVS and retail is during this pandemic. Our ability to scale quickly and spread access to vaccinations and testing, and now treatments. As we know, there are multiple treatments that are becoming available, FDA approved with the pills to reduce hospitalizations, is incredibly important. And I always believe that the role now that a CVS has, a Unity has, these primary care settings, and not too far removed from this place at the corner of 14th and Irving is Howard University Hospital and Washington Hospital Center. The role in which we create this ecosystem to prevent those hospitalizations, those ICU visits, to flatten the curve from cases to hospitalizations to deaths. It's really that ecosystem. So as I reflect on my first 5 years, and I practiced for about a decade, as I continued a lot of that work and was able to continue practicing during my time in the public sector, half a day a week, I will say that I learned a lot about the relevance of science. And as we talk about the science that you typically learn in medical school and residency, but then recognizing the translational science that you're now advocating for in community-based settings, was fortunate to be able to have a number of co-PI opportunities. I do think the evolution of community-based participatory research is incredibly important to assure that we are building evidence that represents the communities we're serving and addressing health equity. And I definitely feel there's a lot of similarities between the public sector, the private sector, and the nonprofit sector. You both need mission and you need to deliver margins. And that was something that I witnessed as a lot of the budgets were accountable and those P&Ls were accountable to me. To deliver care in underserved settings is a real big challenge. You've got to deliver visits and provide access and address health equity, but you've also got to keep things open. And often I remember, we would only have about a month or two worth of payroll in the bank. And we were looking very aggressively to find grants and other funding sources to provide the care that we did for the families we served in underserved communities in DC and Baltimore and broader Maryland. So, the importance of primary care, I can't underemphasize it. Typically 5% of all healthcare spend is primary care, but ultimately it impacts 50 to 60% of spend. I also would say the role of teams, as I discovered, we often train in our silos according to our efforts as we get our doctorate degrees or master's degrees. But as I came into practice, I saw the importance of not only, of course, the patient and their families being a part of that team, having a panel of 2,000 patients, and in many ways having not only the parent, the child, but also the grandparents on my panel as a med-peds physician, but thinking about the role of nurses, pharmacists, social workers, psychologists, and I'd even, add the data scientist who wasn't necessarily in this picture when we did these kind of lunch and learns, but the data science is an incredibly important partner as we were starting to implement EMRs and pull data out of medical records and look at registries and look at health disparity collaboratives. And so the role of trust, I think health and healthcare and fundamentally research is all about trust. and sometimes the inability to deliver or address issues like trials or diversity in clinical trials or vaccine hesitancy or other things are in my mind, an issue of mistrust or lack of trust. So, the importance of these teams, I call them transdisciplinary teams, as was referenced in the prior reference there, the term. I typically we think of multi, inter, and trans. And trans is often, transportation, translation. It's this concept that you go and seek to understand to be understood, that there's an effort made. And I do think teamwork requires transdisciplinary thinking, and it requires a common medical record, a common set of data, and a common recognition that that patient I take care of on the left, in many ways is trusting me, but also trusting my whole team. And we have to be thoughtful. And this is once again where I think the role of pharmacists, for example, I've learned quite a bit. We have 40,000 plus pharmacists at CVS, 60,000 pharmacy technicians that are playing a very important role during this pandemic in terms of delivering vaccinations and testing. So once again, the importance of team, but now thinking about the team as a whole. I was fortunate to serve on the board of the Association of Clinicians for the Underserved. This was a board meeting, and we took a picture and we were distracted with someone making some noise, so the picture was taken there. But looking at the Quadruple Aim, as you think about the work you do, we often think about the Triple Aim originally with the Institute for Healthcare Improvement, measures of outcomes, population health, cost, and patient experience, or we're very focused on member and customer experience. At CVS Health, I like to say we've got 80 million Americans who have access to our extra care cards, those cards that provide you access to discounts and little nudges about different things. There's about 100 million, 110 million Americans who have our pharmacy services. So the access to your drugs, your medications, 1 in 3 Americans get access through our pharmacy services segment. And then Aetna, the healthcare benefits part of the organization, provides services to 40 million Americans. When we think of measures or HEDIS measures or measures of success, when we look at how we are delivering care, we think in terms of cost, quality, and member experience, typically customer experience. The part that I want to emphasize is that the Quadruple Aim talks about provider experience, as we think about health and healthcare delivery. So the experience of providers, and I think in this moment, there is so much burnout that is happening, and we need to be sensitive about physician burnout. Pharmacists are burning out. Our frontline healthcare workers are burning out. So we have to think in terms of that. And as we think about our provider networks that we facilitate, we are also thinking about the provider experiences with us as CVS Health, as Aetna. And I just want to emphasize that as you think about measures in science, making sure you're reflecting the people who serve as well as the people who serve. And this was a study that we did, a systematic review with Mayo, folks at Mayo, and published in Mayo Clinic Proceedings. Once again, that emphasis on transdisciplinary. I like to say that in many ways, as we look at the future of health and healthcare, we and the transformation that's starting to occur, we have to think in terms of all the disciplines that play a role. They need a common record of sorts. That's ultimately, in my preference, it's the patient's data, it's the member's data, it's the customer's data, and they have this recognition that there is a family, a team that is committed to, accessing that data, leveraging insights, and delivering better care. And so this is a very important principle, and we're proud of the fact that we've got now. We want mental health to be as accessible as Tylenol. We are putting social workers in many of our sites, so you could have face-to-face interactions there, also virtual interactions. We obviously have pharmacists at each of our sites. We have nurse practitioners at a large percentage of our sites through our minute clinics and physician assistants. We have health hubs, which are a place to think about people's journey to health. And these are, in many ways, I call them community health workers. The model is these are folks who represent the community, typically are representing those diverse communities we serve, and they're trained in, like community health workers are trained. We've got physicians, nurses, case managers. So this transdisciplinary team plays a very important role. And, to me, that's such an important ingredient of success in research, but also in care delivery. I love this one picture. This is the first site we went in Hartford, Connecticut in December after the speed of science accelerated the vaccines. As you recall, there were long-term care facilities. We knew that the science showed that there was a high risk of deaths and cases and mortality and morbidity for elderly and those with multiple chronic conditions. So we at CVS Health moved our pharmacists and pharmacy technicians, over 100,000, and mobilized them to deliver vaccinations at sites. And we did actually 40,000 sites. And if you look at the statistics of the cases, the hospitalizations, and the deaths, I would attribute a big reason why cases went down by 95%, deaths by 96 or 7%, was because of our efforts to deliver that care in those settings. And this was the first person we vaccinated at a long-term care facility in Hartford, Connecticut. So, we're looking at boosters, of course, now, not only at our stores, but, in terms of long-term care facilities and workplaces and healthcare organizations, as we know that is an important component as well. So that was kind of, a bit of the more care delivery perspective. I was fortunate with Dr. C and so many amazing public servants to have a moment and be at NIH and HRSA at a moment where there's the Recovery Act, the Affordable Care Act. There was such excitement about health equity and the opportunities to cover people who are uninsured and low income and expand coverage. And we know since that law has been passed, there has been a significant decrease in the uninsured and significant increase in coverage of Medicaid, which I witnessed because the majority of the patients that I served in DC and Baltimore in the roles that I had were Medicaid or uninsured populations. So I think the policy piece, like we often, and Francisco knows this, we created a NIH summit on eliminating and reducing health disparities. We had 4 different work streams. I think it was very powerful to think that science is the foundation, but ultimately, how do we translate science into practice? How do we translate science into education and training and infrastructure? And how do we translate science into policy? And I will tell you, it was exciting for that 2,000-page legislation. A large percentage of that legislation was attributed to HRSA actions like the Women's Preventive Services, the expansion of the federally qualified health center system, the expansion of the National Health Service Corps, which I benefited from. We were the agency that had the second most pieces of legislation next to CMS. And so it was exciting to see how science played a role in good policy. I'm not saying it's 100% always like that, but I would suggest that in many ways, as we quilted that legislation together and worked with members of Congress and Senator Kennedy's office, as we were looking at investments, the demonstration of the impact of federally qualified health centers, of National Health Service Corps placements, of the Maternal and Child Health Bureau investments, of the Ryan White program. These all played an important role in us, supporting the science behind some of the policies in the legislation. So don't underemphasize how your science can lead to scale and policy. This is another way I learned, and part of it was, the fortunate opportunity that I had often to speak publicly with different stakeholders about the Affordable Care Act, and it gave me an insight into the broader system. I had a sense of the system in community-based settings, but at a more governmental public health perspective, it was fascinating to see all these stakeholders come as we talked about the Affordable Care Act, as we talked to people about how we implemented it and looked at prioritization of eligibility requirements for studies and grants or investments, and so I would suggest that this piece in the Institute of Medicine, now known as the National Academy of Medicine, highlights a powerful statement that is incredibly relevant today with the pandemic, that we often think of healthcare, vital to us some of the time. Many of us, use healthcare quite a bit, but ultimately public health is vital to us all the time, especially you could see it during a pandemic. So I like this graphic, although I've used the 7 Ps as an acronym to remind myself how money and data flow in healthcare. It goes from the 7 Ps of patients, providers, payers, because in many ways that interaction between a patient and a provider leads to a payer like an Aetna or a United, a purchaser, an employer makes that design, they're policymakers on their own. And most of our healthcare for the working Americans is employer-based insurance. Most of you probably get your healthcare from your employer. Your employer has the ability to strategize and be innovative about health benefits design in terms of what is or isn't covered, and to promote equity in design. I'm proud, for example, at CVS Health that we look at low-income individuals and subsidize 95% of their benefits for healthcare, while higher income folks like myself are subsidized at more like 65%. And so I have to contribute more so that people who are lower income contribute less. So the role of the purchaser is incredibly important. Product manufacturers, big pharma, medical device companies are trying to innovate. Policymakers is another P, governmental public health, whether it's federal, state, county, city. There's so much opportunity in terms of the role of governmental public health. Institutions like NIH are governmental public health. They provide an important infrastructure, often the spine for different parts of public health. The central nervous system of sorts, a convening power and an ability to connect the dots, almost like a primary care clinician with a diversity of specialists. They can play an important role. So governmental public health is really important, policymakers. And the last one is I put you all in this category of being pioneers in academia, startup companies. You're looking to really look at the future and look at ways you could advance science and really change a dynamic. So I often refer to those 7 Ps: patients, providers, payers, purchasers, product manufacturers, policymakers, and pioneers. And in many ways, I view you and the work, as I looked at your studies that you're doing, as really pioneering the science and translational research. This was a piece I published in Fortune, and I've learned the importance of publication in multiple settings throughout my career. There's one setting, of course, which is the peer-reviewed literature. But then in my mind, there's such a huge opportunity to think about, other sources of telling a story and talking about the importance of health, and places like Fortune, Forbes, and where there's a broader, audience. I was just interviewed yesterday by CNBC as it relates to the importance of health insurance and the enrollment period, especially during the pandemic, with the enrollment timelines for our exchanges, the state-based exchanges and the federal exchange, and the subsidies that are available there. So I wrote this piece early during the pandemic about the importance to flatten multiple curves, that we have to think about the curves of course, COVID, and it's so important that we're all appreciating health in this moment. We're all thinking about business models and approaches to health and healthcare, and even jobs. I mean, there's been a great resignation. Many people are rethinking where they get their jobs and whether or not they need to be in person. And in a virtual world, I would argue we're competing, in a very different way. My children, my daughters are going to compete with a much more global economy, and they've got to compete for jobs with people in India and China, in Brazil, and in Western and Eastern Europe. So we have to think. So now we're all learning about public health literacy, flattening a curve, but there are other curves besides COVID, infectious diseases, the twindemic of the flu right now, mental illness, chronic diseases, which of course you could put as a category of mental illness, as a category of chronic diseases, things like substance abuse. We've seen incredible data where the increase of mental illness has gone up, the utilization of mental health services, 2/3 of all of our visits for mental health have now converted from the more traditional face-to-face to virtual, and that is a perfect type of condition to provide virtual. I would suggest that I believe half of all visits that have typically been provided face-to-face could be delivered virtually. Even like a post-op, check-in. Do you really have to go into a doctor's office and get that seen? Couldn't you do some of that virtually and see someone's mobility and someone's wound, and maybe not have to expose yourself to a waiting room full of sick people, and all the travel that's required. And health disparities, health inequities is another curve that we need to flatten. So I like to imply that these are areas we need to think. I call this an evolution of values-based care. What are the values we believe in? Mental health, resiliency, prevention, equity, science. And that's this new age I think this pandemic is challenging all of us on. I also like to emphasize here the importance of health and healthcare. So health, we have this program. We do screenings for underserved communities. We often do it with churches, community-based organizations. We do it with the Y, where we have our staff go there and do screenings of diabetes, hypertension, and other chronic conditions, even depression screenings and such. And we've discovered in 1 in 3 cases, we're giving someone a potential diagnosis that they were not aware of: diabetes, hypertension, high cholesterol. 1 in 3 cases, as we know in health disparity communities, they often are diagnosed at later stages of their disease when it's much harder to treat. And so we've leveraged our network, and this was pre-pandemic, this picture, but Project Health has been in place for 16 years. And we do free screenings in many communities in partnership with community-based organizations all across the country. And I just think the acronym of health, housing, education, access to healthy choices. We gave up tobacco 6 years ago, lost $3 billion approximately in revenue. We're the only major retail entity that forgave tobacco. This concept that you could get your meds and buy a pack of cigarettes was counterintuitive to our value prop. And so access, promoting access to healthy choices, labor, transportation, and healthcare is the acronym I use. For health, we need to think broader than just healthcare. And I know all of you think about that. This is the last piece of my career, the last decade at IBM. So health tech, I learned so much about the principles I just referenced about the different stakeholders there on the bottom. The 7 Ps are kind of referenced: payers, providers, pharma, policymakers, government, pioneers, researchers, patients. Sometimes people think of purchasers and payers the same. That's the difference between, we have Home Depot and Bank of America as clients. They're purchasers, but we are the trusted health plan as a payer. The opportunity to do design. And I looked at this across IBM from a data perspective in terms of the data we sold, the analytics we sold, the hardware we sold, the services and consulting services we sold across the globe as the chief medical officer for IBM. But I also had the benefit of looking at the spend of IBM in healthcare. And so we spent over $5 billion a year on healthcare in 170 countries for at one point nearly 400,000 employees. So, and then you think about all the dependents and all the retiree health that we supported. And that's $5 billion. And to design that and think of how you spend that money and how you prioritize for in places like the Philippines, or to make sure we cover contraception, family planning, which was fairly controversial, and prenatal care, things we take for granted in the US and in industrialized nations, in the developed world, mammograms, pap smears, colonoscopies. In many parts of the world, those are not covered. The benefit design are typically covering just what I would call crisis insurance, like if so you don't go into bankruptcy. These preventive services are typically not covered: chronic disease medications and these preventive services. And I was so proud of the fact that we created a consolidated benefit design in many parts of the world where we saw, we eliminated pre-existing disease exclusions like mental health. Many parts of the world, like parts of sub-Saharan Africa, where we had a number of employees, you can discriminate against people based on HIV status or mental illness You can say if you're depressed, you have HIV, you're excluded from the health plan. You can actually do those screenings. So these were all things we as an employer decide as a purchaser of care we were going to do. It did increase costs short term. Many of the health plans thought, how am I going to do this? How am I going to cover this? You're putting me at risk. I wanted to eliminate those 15 to 20% of people with HIV and not cover them. And it would have reduced your cost as an employer. But we thought, that was wrong. And we as an employer wanted to change the paradigm of what was covered and address disparities from a benefits design perspective. So I just want to imply that there is a huge opportunity there as we think about the role of the employer in culture and a culture of health. This is how I frame it. We published with folks at Harvard. John Quelch was one of the few people at Harvard who had a degree at both the master's MBA school and the School of Public Health, where I've seen Francisco's picture there in the dining hall, him as a graduate. Dr. C is there if you go get your food there at the School of Public Health at Harvard. But one of the pieces of work that we did in partnership with them and funded by the Robert Wood Johnson Foundation is this recognition. This is pre-pandemic. I think everyone during the pandemic recognized this, that when you think of a company, an organization, you have to think in terms of these 4 quadrants of health. How do I take care of my workers? From a benefits design, from a strategy, from, of course, now COVID vaccination requirements. We have a COVID vaccination requirement for our workforce. Many people are struggling with these issues. Then what you sell. I just mentioned how we got rid of cigarettes and tobacco and lost $3 billion worth of revenue. We did a study in the American Journal of Public Health that showed when we eliminated tobacco, we actually reduced the smoking rates in those parts of the community where we're the predominant pharmacy or retail store. Environmental health, thinking about the impact of health and climate change, and especially for disparity populations, this is going to be a big issue. So supply chain and thinking about carbon emissions, and then community health, thinking about not only the workforce but the people we serve. So all 4 of these quadrants are incredibly important when you think of data and commitment to create a culture of health in an organization. I also think this is important. I learned about the importance of humans in tech. We were fortunate early to have so much attention. There were many AI winters. If you look at the science in the 60s, the 70s, the 80s, the 90s, I'd say that IBM has the best AI and created amazing research, leader in patents for 27 years, and really did studies on the piece on the bottom, how you can use it for natural language. A lot of the technology that you now see with products that you see in Alexa and Siri and others, natural language processing has gotten much better. A lot of that technology, the history of that is IBM technology, pattern recognition, locating a piece of knowledge. Humans do these things on the bottom really poorly, and we should let humans do what they excel at and let tech do what they excel at, and then combine these 2 together. This has never been about replacing humans with tech. This has always been about the synergies here and letting the tech do the things it does really well. I mean, imagine Google, that's a piece of tech, right? Locating a piece of knowledge. How much has that improved, our ability to find things? So I remember, Encyclopedia Britannica, not to suggest that everything on the internet is accurate, but, this idea that we've got an opportunity to leverage tech to advance, areas where many of us spend a lot of time. I remember doing lit reviews, studies. There's so many ways you can leverage tech to do those studies and the lit reviews for yourself. And we applied some of that technology in some of the research that we did. But you always wanted to complement with humans and what they do best there. The 3Ds, I was part of the 3D commission looking at the importance of data, determinants, and decisions. I like to say it starts with the determinants. What are the determinants you care about? Do you have data in those areas? Things like housing, education, the health acronym that I use, labor, transportation. You have to consider healthcare as well. And then sometimes you have gaps in data. Don't let perfect be the enemy of the good. And then you need to bridge that to decision makers. And you need that flow to go really well to those 7 Ps. You need the data and the insights to represent the right determinants to make the better decision. So in that moment, that a doctor sees a child or that a policymaker is making a recommendation on legislation. Ideally, you want that in your workflow. You want the right information at the right time to make the right decision. So just want to emphasize this is another piece of learning that we learned quite a bit at IBM. If there's a delay in data and insights, if it doesn't represent the right determinants, and you give it to the decision maker at the wrong time, you really get bad decisions. So Tequity is another concept I'm very proud of. We published this in the Meharry Journal of Healthcare for the Poor and Underserved in May of last year. And this is a piece of work that I'd been promoting since 2004 or 14, I mean, at IBM. As I learned about tech more and the importance of health equity, I love the reference to the Quadruple Aim. The National Academy of Medicine published this study on AI in healthcare, and they talked about the Quadruple Aim, how we need to really pull out equity inclusion. Remember, I referenced the Quadruple Aim, which includes care team well-being, as well as patient experience, as well as pop health and reducing costs. But let's think about this. Tech and healthcare do a terrible job, and I would argue even major parts of academia do a terrible job of workforce diversity. You have to represent the people you serve. So we need to do a better job of that. Then I would say that is like foundational. And I see it, I'm often the only minority in meetings and C-suite meetings and such. I'm still frustrated by the fact that our diversity in the C-suite in corporate America is not sufficient. And that needs to change. You need to look at data trust, data collection. I'm proud of the fact in our vaccine effort, we get about 98% race ethnicity data when people register for a COVID vaccination at a CVS, cvs.com. We did that very purposely because we needed to collect that data to demonstrate that we're addressing disparities and that we're reaching out to health disparity populations, Black, Hispanic, and we've done a great job. About 40% of all the vaccinations we've delivered have been non-white minority populations. I also think the fact that our pharmacists are non-white and our pharmacy technicians, 40% of our pharmacists are non-white, 50% of our pharmacy technicians are non-white, I think plays an important role in also people trusting us to get those vaccinations. But data trust is important. I think equity dashboards should be standard. And I think we have to think purposely about AI and machine learning that's being applied everywhere. Are we inadvertently worsening disparities or extrapolating disparities? If the data sets we use are not representative of the populations we serve, we have a major danger of just keeping the disparities that currently exist. So this is the concept of tequity. The last two slides here is about transformation, and I think the future of values-based care. I think this pandemic is making us realize the value of equity. George Floyd and the terrible numbers that you see in terms of loss of life expectancy for African Americans compared to other groups with this pandemic, the issue or impact on mental health. You know, do we value mental health and mental health equity? Do we value prevention and science as values are really important? You know, we should prevent diseases like COVID. We shouldn't just treat them. We should prevent chronic diseases, right? So we're invested in primary care. We're going to continue to invest in these neighborhood pharmacies, and we want to be the front door to primary care. Recognizing that primary care, while it only represents 5% of all healthcare spend, it probably influences 60 cents on the dollar, but also it is a value prop for us in terms of a role we can play. We know there's gaps in primary care all across our country as well. So I think of CVS, even though it's technically stands for Consumer Value Store, I think of it as community, values, and service, from the home to the palm of your hand to the health hub in your community. So that's my last slide, referencing vulnerability in this vulnerability moment as well, and just believing that it's a catalyst for innovation, creativity, and change. And I know all of you are committed to that innovation, creativity, and change, and translation of your important research into real world practice and policy.
Thank you, Q. Any question for Dr. Rhee? We can entertain at least one question. If not, I think we want to thank Dr. Rhee for spending time with us and sharing with us all his 7 Ps and treaties. And your lectures are recorded, so you can share with our members across these 6 states. Thank you, Dr. Rhee.
Oh, thank you, Dr. C, Dr. Reed, Dr. C. Dr. C is awesome. So I love Francisco. So I just want to thank you. You're lucky to have him as your leader, your PI, and a teacher. And I learned a lot from you, Dr. C. So thank you so much for having me. And I put my email in there. I'm always a big believer in relationships, especially during this pandemic, and supporting each other. So if there's anything I can do personally for you, please feel free to reach out. But thank you, Francisco.
Thank you.
Okay,
Thank
take
you.
care. Okay, bye.
Okay, I think we can continue on with our program, and Tabitha can show the slide, and you can see the our program for the rest of the day. Curtis, and we'll have a short break and 10-minute break, and then we'll resume at 12:55. And Curtis and from University of Montana and Scott from University of Wyoming will moderate the presentation of the pilot grantees this afternoon. So take a 10-minute break. We'll be back 12:55 Pacific time.
Francisco, are you okay if we get started?
Yeah, Curtis, I think we can start.
Okay, great. Thanks very much. And so thanks for joining us, everyone. For these next 2 sessions, we'll have 3 presentations from CTR-IN awardees, followed by a short break, and then 3 additional presentations. So 3 presentations, each of 20 minutes, 15-minute presentation, 5 minutes question and answer. And so I guess I would request a couple of things of our audience, is if at all possible, maybe you could enact your video camera. Just it makes it easier for our speakers to see faces rather than names. So if you can do that, please do so. And secondly, please think about questions you might have for our speakers. You can certainly put them in the chat window, and Scott and I will try to moderate the chat window and manage questions as soon as the presentation is done. Please feel free to interact in that way. So our first speaker is Christopher Soroka from New Mexico State University, and he is going to be talking about modeling disparities in obesity along the US-Mexico border. Take it away, Chris.
Okay, thanks, Curtis. And if people have questions halfway through or partway through the talk, feel free to interrupt. The way I have this set up with the full screen, I can't see the chat, so feel free to flag me down somehow.
Sure.
I'll start with the background of this project and what our objectives were. What we call the US-Mexico border region is a very specifically designated geographic region in the United States and in Mexico. On the United States side of the border, it consists of 44 counties that are within 100 kilometers of the international boundary. And so these are the counties that span the states of California, Arizona, New Mexico, Texas. In total, in those 4 states, there's 360 counties. But what's researchers, when they focus on the border region, they're specifically focused on these 44 counties. Now, the population living in this border region has some characteristics that make it different than the rest of the population in the United States. It's primarily a Hispanic population. A large percentage of the population lives in poverty and lacks health insurance. That's both, with across the nation, and when you compare the region to the rest of the nation, but also when you compare it even within the border states. So those 44 counties have a larger share of the low-income Hispanic population compared to even the rest of the states that they're contained within. And it's believed that these socioeconomic characteristics are root causes of chronic diseases and other health problems in this region. Now, there's a problem in trying to study this population, is that there's very little data out there, and it's very difficult to obtain the data to study them. Because it's primarily rural, when either state or the federal government runs large population surveys, it often misses this population. Just if you randomly pick people from a population, you're automatically going to get them from urban areas because that's where most of your people are in the first place. Trying to run dedicated studies on this population is oftentimes difficult and expensive because you're going into very remote areas. You don't have good listings of the population that you can sample from. It becomes difficult to actually recruit population from these areas. So we have very little data about some of the chronic conditions in this population here. So the purpose of this study was to use what secondary data is available to try to study the prevalence of obesity in the US-Mexico border region. And we're focused on two key questions here. Is there a disparity in the prevalence of obesity between the border region and non-border region within the states that we're studying? And what's the spatial distribution of obesity along the border? So are there particular counties where obesity is a problem? And does that suggest that maybe these are locations that would be prime targets for trying to study some kind of interventions that might help reduce this disparity? So here are the methods that we used. We relied primarily on the CDC's Behavioral Risk Factor Surveillance System, or BRFSS data, for the 4 border states, California, Arizona, New Mexico, and Texas. These data have questions on self-reported height and weight, as well as demographic and socioeconomic information. We can use the self-reported height and weight to calculate BMI and then come up with a measure of is the person obese or not. Now, it is self-reported, so that's an issue, and there's a whole side work being done in this area, trying to correct self-reported data for clinically confirmed data. There tends to be a downward bias in BMI and other types of anthropometric weight measurements when it's self-reported. So we have to recognize that maybe some of our numbers have a slight downward bias in terms of the prevalence. We had to rely on limited release data sets from the states. So we obtained these limited release data sets from each state individually. CDC used to include county of the respondent on their data releases, but they stopped that about 10 years ago. So you used to be able to do a lot of this county level analysis with the publicly released data set from the CDC website. Due to privacy concerns, they started masking counties. So we entered into data use agreements with the 4 states that allowed us to use these data, and they gave us the data sets with the county identifier on there. Now, because we're primarily dealing with counties that have low populations, these rural counties in the Southwest here, it's typical to pool data together. So we pooled data together for 2015, 2016, and 2017. Now, the BRFSS is not a random sample. It's a very complex phone sample that uses both landlines and cell phones. It has a very complicated survey weighting scheme attached to it. So when you analyze these data, you have to apply the survey weights to get unbiased population estimates. When we combine the 3 years here, you also have to do an adjustment to your survey weights. If you didn't, you would end up with 3 times as many people in every category because you're combining 3 years. So we did some adjustment to the survey weights there. We used a logistic regression to try to find associations between whether a respondent was obese and whether that respondent lived in a border county. So sort of the main predictor of interest here is, was the person in a border county or not? And the outcome was whether they self-reported as obese or not. We adjusted for the respondent's age, gender, race, ethnicity, and then we included an interaction effect between race, ethnicity, and border county. And that actually showed us some very interesting results. And the purpose of that interaction is to look at whether or not race ethnicity plays a different role, whether you live in the border county or you don't. And then to try to understand something about the spatial distribution of obesity along the border, we ran some Bayesian hierarchical models. that provided us with what are called small area estimates. So it allows us to estimate in each county the prevalence of obesity, broken down by age, gender, race, ethnicity, and even in these counties where we have very, very small sample sizes or no sample sizes, the models are able to give us estimates of the prevalence of obesity there. So the Bayesian hierarchical models are needed because of these, low sample sizes or zero respondents in particular counties or in particular class. In particular, there's 3 counties in Texas that actually had no respondents at all. They're so rural, so sparsely populated. When the BRFSS tries to call people up randomly across the state, you have a very almost impossible chance of being selected from these counties because there's so few people there. So this modeling, this advanced modeling is needed to try to come up with estimates of those areas. And the main principle is what it does is it looks at the overall relationships among obesity and these demographic factors across all of the counties, and then kind of extends that relationship to these counties where we don't have any data to try to come up with some predictions and some intervals that will help us to understand that. I see there's a question in the chat. Does BRFSS data set include dietary intake data? Not in a very precise way. I mean, you're not going to get anything like ASA24 kind of recall data. They don't include that. I don't think there's a particular, they might have some vague questions about consumption of sugar and that kind of thing, but nothing of a level that you would get from a real intense kind of dietary survey that a lot of nutritionists like to use. And again, it would also be a lot of it's self-reported too. It's not like a diary type data or something like that. So I'm going to switch screens really quick to kind of show you our results because I wasn't able to get our maps into our, let's see here. Wasn't able to get our maps into our presentation very well. So pull up my map. So this is sort of a map. This kind of gives you a better sense of the border regions. So our 4 border states, California, Arizona, New Mexico, Texas. The red outlined counties are the ones that are border counties. These are our counties that are within that 100 kilometers of the border there. So those are the ones where we're particularly focused on trying to look for health disparities. And so you can see here, these are the estimated prevalence rates for each of the counties. This incorporates our modeling as well as our the survey weights that go along with the BRFSS. And this is just overall, it's not broken down by the different particular groups, but this just gives you a sense of sort of the spatial distribution of obesity in these regions. And you do see there's a couple of counties along the border where there's a particularly high prevalence of obesity, particularly some of these counties in Texas there, kind of along the Rio Grande there. Some of the 1 or 2 in the kind of near El Paso area. Imperial County over near California also tends to have a higher prevalence rate. So kind of gives you a sense of the distribution of the spatial distribution of obesity in the region. We've developed some different maps around these issues. Getting back to my slides here. So that kind of gives you kind of an overall picture of kind of visually what the distribution of obesity is like in there. Kind of, you don't get a sense of, well, is there really a disparity between the border or not simply by looking at the maps. So this is where our analysis came in. So we look here, it's looking at just comparing the prevalence of obesity in the 4 border states. If we compare the border region to the non-border region, so those 44 border counties to the non-border counties, you really don't see much difference in the estimate of, or the prevalence of obesity between those 2 in the border region. And we estimate that the prevalence of obesity is 29.3%. In the non-border region, it's 28%. When you break it down by race ethnicity, though, and this is where that kind of interaction in our model kind of sheds some light on this, what we see is that the disparity between white Hispanics and white non-Hispanics between the border, in the border region is much greater than it is in the non-border region. So for instance, white Hispanics in the in the border region have an estimated prevalence of obesity of 37.6%. Well, when you compare it to white non-Hispanics in the same border region, we see that it's 22.7%. So there's a 15 percentage point difference in the prevalence of obesity between these two groups within the border. When you look at the non-border region, we still see a disparity, but it's much lower. So white Hispanics in the non-border region have a prevalence of obesity of 34.2%. White non-Hispanics have a prevalence, estimated prevalence of only 26.3%. So only, about an 8% difference. So the disparity is much, much greater in the border region than in the non-border region. From our logistic regression analysis, we're able to come up with some estimated odds ratios comparing these different groups together. And again, this is adjusted for other factors that we include in the model related to age and gender and other things. And we see that, when you compare white Hispanics between the border and the non-border, we get an estimated odds ratio of 1.15, but it's not statistically significant. So we don't really see much of a difference in obesity prevalence between white Hispanics in the border and non-border. So it's not as though Hispanics in the border region are more likely to be obese than outside the border region. What's more likely to happen is that white non-Hispanics in the border region are much less likely to be obese than their counterparts outside the border region. So there we get an estimated odds ratio of 0.83, and it is statistically significant. So where this increase in the disparity comes from the fact that white non-Hispanics in the border region tend to be less likely to be obese than they are in other parts of the states. And so you could see that if you're looking at the comparison between white Hispanics and white non-Hispanics within the border region, if you're a white Hispanic in the border region, you have an odds ratio, your odds are 2.18 times higher of being obese than if you're white non-Hispanic within that same region. But that comparison is only 1.57 when you're looking outside the border region in these 4 states. And then kind of going back to this, just put some detail on some of that spatial distribution. Here are some of the counties. So what we did, we went back on each county, and within the county estimated the disparity. So what's the percentage point difference in obesity between these two groups? And so we identified some counties where there's sort of the highest disparity in obesity between the two groups, between white Hispanics and white non-Hispanics. And those tend to be in these smaller rural counties: Sierra, New Mexico, Uvalde, Texas, Webb, Texas, Edwards, Texas, Imperial County in California, and Hidalgo County, New Mexico. You can see this is sort of the estimated difference in the percentage point difference in the prevalence of obesity between white Hispanics and white non-Hispanics within these counties. So our overall conclusions from this project is that prevalence of obesity is not much higher in the US-Mexico border region than the non-border regions in these 4 states. However, the disparity in the prevalence of obesity between white Hispanics and white non-Hispanics is much greater in this region that we're studying. And it's driven by the lower prevalence of obesity among white non-Hispanics, rather than there necessarily being a higher prevalence of obesity among white Hispanics. And so there's some future work that's needed here to try to examine the factors that contribute to lower weight among white Hispanics in the border region. It suggests some kind of accessibility issue, right? So, I mean, if you're controlling for all these other factors in the border region, there's something that we're kind of missing that suggests maybe an accessibility issue, something that's accessible to white non-Hispanics in the region that's not necessarily accessible to white Hispanics in terms of helping to reduce the risk of obesity. So I'll stop there and leave time for questions. I think we have time.
Great, thanks so much. I'm going to turn it over to Yimin Chen. Would you mind putting forth that question and just unmuting Yimin?
Yeah, absolutely. Thanks so much for the presentation. This was very interesting to look at a very specific, potentially at-risk population. I appreciate the work. I'm just curious, I think you mentioned that you included some socioeconomic status data in your data analyses. Is that correct?
Yes.
And then,
as is captured by the BRFSS as they reported, yeah.
Gotcha. And then the other question I have is, I'm wondering if BRFSS, I'm just not familiar with the program or the program itself and what they assess. if they have any data that allows you to assess the type of places that people would get food from. I'm thinking in terms of like food deserts and food swamps is, you know, certain geographic locations that can contribute in addition to socioeconomic status.
Yeah, they don't get into that much detail. So sort of the BRFSS is sort of a general health. It's sort of, I wouldn't say quick and dirty, but it's a general health survey that the CDC does to monitor health year after year after year. So they ask so many questions that they can't get into any detail on any specific topic. So it includes things like vaccination and how often you see your doctor and lots of different health condition types of things. Have you ever been diagnosed with diabetes?
Are you aware?
Tons and tons of stuff. So what we're hoping to build off of from this project is it is difficult to get into that detailed data, but if we could try to link it to some smaller scale surveys that get into that detailed information, we can try to link the two together and try to answer those types of questions. And so, and it's a whole field now that's popular in statistics called data integration, where you can take certain small scale non-probability samples where you get into the details of, you know, where you buy your food, have, you know, food security questions, those kinds of things, and link it to this much bigger data set on health to try to draw those linkages. And so that's what we're trying to hope to build off of from this project.
Wonderful, thank you.
Yeah, thanks so much. And just so that we stay on time, I'm going to transition to our next speaker, but I'm going to ask Christopher to go to the chat because there's a few questions in there, and I'd love for you to, during the transition, to try and respond to those if you could via chat. And
sure.
Thanks very much. That was a really fascinating presentation.
Thanks.
So our next presentation is actually a recorded presentation by Barbara Gordon from Idaho State University. She was not able to join us today. And Tabitha is going to launch this presentation for us, and hopefully it'll all work smoothly. Go ahead and give it a go. I don't know if that's Sabina or Tabitha.
Hello, my name is Barbara Gordon. I'm with Idaho State University, and I'm going to present the findings of the Anti-Inflammatory Diet for Interstitial Cystitis, a randomized controlled crossover trial evaluating the efficacy of an anti-inflammatory diet on symptom severity among women with interstitial cystitis, bladder pain syndrome. Going forward, in the interest of clarity, I'm going to refer to interstitial cystitis, bladder pain syndrome simply as IC. I have nothing to disclose. This is our research team. The primary investigators include myself and Dr. Cynthia Blanton, who's also in the Department of Nutrition and Dietetics at Idaho State University. We also worked with Dr. Holz, who is with Medical Lab Sciences at Idaho State. And we had 3 graduate students who were really key in terms of making this study a success. Andrea Jeffrey, Rebecca Ramsey, and Laura Ritchie. They did a great job. IC is a chronic pain condition. It's characterized by pelvic pain. Pressure and discomfort are felt in the bladder and the pelvic area. There's also urinary frequency and urinary urgency accompanying the pain. At this point, we do not know what causes the condition, and there is no cure. It occurs in both men and women, though it appears to be more common in women. The treatment requires an interprofessional multimodal approach. It really targets in on the symptoms and managing the symptoms and trying to diminish the severity of symptoms. And part of that treatment is dietary modifications. There's been a series of self-report studies from which a list of typically bothersome foods has been compiled. And these foods generally irritate the symptoms in 90% of women with IC. What we found in clinical experience is that because these foods include citrus fruits, tomatoes, red peppers, that often what women do is they restrict their intake of produce that's really rich in antioxidants and increase their intake in saturated fat. And that behavior is to avoid a potential risk of an IC flare. So we have this population that is drifting towards a high saturated fat diet in order to prevent pain in the body. And there has been research that has shown that diets that are high in saturated fats can stimulate pro-inflammatory responses. And there's also been research that has linked changes in bladder on a cellular level to intakes of saturated fats, which may increase urinary urgency and frequency. So this suggests that there could be a link between a diet high in saturated fat and the symptoms of IC. But to date, no study has explored this premise, that no studies have been published that have controlled lipid intake and increased antioxidant intake in order to evaluate the impact on IC. And that was the goal of the 8IC pilot. We investigated the efficacy of an anti-inflammatory diet on IC symptomology. This was a mixed method study. The nutrition intervention was implemented across a 6-month period. It was a 22-week crossover protocol. There was a 2-week washout period. The focus groups were conducted post-intervention. The anti-inflammatory diet was primarily plant-based. About 28% of the calories were from animal foods. Foods found to be beneficial to controlling inflammation were included. Items that increase inflammation and those commonly bothersome to women with IC were not included. Each meal was about the RDA for micronutrients. We did get some recruitment assistance from the Idaho Urologic Institute, which is a specialty medical practice in Meridian, Idaho. We also had a web presence on the ISU Nutrition and Dietetics website. Participants received home delivered meals for lunch and dinner for 5 weekdays. We contracted with a service out of California, Meal Pro, who provided the meals in vacuum sealed microwave oven safe containers. This is a picture of 2 of the meals. They were able to stack them for cold storage. Participants got 2 weeks at a time. The dietitians provided a menu with breakfast options and weekend meal menus. We did also provide recipes. During the control phase, participants were responsible for their own meals. And they did meet with the dietitians who counseled them on avoiding their individual IC trigger foods. We collected 5 different types of data. Participants met with the dietitians 4 times. They met with them at the beginning and the end of each of the 10-week phases of the crossover intervention, and a 24-hour recall was done. We wanted to make sure that there was a difference in terms of saturated fat intake, but we also wanted to see if there was a difference in terms of the nutrients that are associated with anti-inflammatory activity. We also had them do 3 validated surveys for individuals with IC, and here we were looking at the level of disease activity. They came another time for blood draws so that we could measure anti-inflammatory markers that are often active in individuals with IC. We also had an online survey that we sent out at the midpoint of when they were on the therapeutic diet to assess acceptance and palatability of the diet. And lastly, after the intervention, we did online focus groups to get participant perceptions. COVID impacted our enrollment significantly. We ended up having to reduce the enrollment period to 2 months. During that time, there were 37 women who were referred to us, and of those, 12 were enrolled in the study, and 10 out of the 12 completed the study. We also struggled to get a diverse sample size in the study. Most of the women were over 45 years of age, which is not uncommon. The typical age of diagnosis of IC is in the 40s. Our sample was 100% white, and this is really reflective of Idaho. It is not a very diverse state, and we were pulling from a region in the state which is not very diverse. But also, we do see a higher prevalence of IC among Caucasians, so that might be reflective of our lack of diversity as well. Most of the participants were married and living with family. One thing that did surprise us was the income level. 3/4 had income of over 50,000, and of those, if you look on this chart, 4 of the 12 had incomes of over 100,000. So this is really high income for the Boise region. This is a snapshot of the findings. So the first column, dietary intake, we did a testing effect analysis of time point, looking at the beginning versus the end of the time that the participants were on the therapeutic diet. So there was a significant difference in terms of the intake of solid fats and saturated fats, as well as refined grains. There was also a significant change in terms of seafood, which means there was an increase of omega-3 fatty acids and a vitamin B12. Unfortunately, when we looked at the significant changes in terms of some of the micronutrients we're interested in, which have been associated with anti-inflammatory properties in the body, there was not a significant change in intake. The next column reflects on disease activity, and we did see some significant improvements in terms of disease activities. We saw significant decreases in terms of pain and urinary symptoms, and positive changes with regards to intimacy, which is a big deal for this population in terms of quality of life. Because you can just imagine if you have extreme pelvic pain that is enhanced during intimacy, that it could really cut into that time for you. The next column has the findings on the inflammatory markers. So we looked at TNF-alpha and IL-1, as well as C-reactive protein. Unfortunately, we had a mishandling of blood samples by the vendor, and so we only had 4 viable samples for analysis, which was too few to really determine if there was any significant change made. With regard to acceptability and palatability of the therapeutic diet, participants were given an online survey at the midpoint of those 10 weeks that they were on the 8IC diet. We found that there was one outlier. There was one respondent who put the worst score for all of the questions, so we controlled for that outlier. And, you know, the therapeutic diet we did okay on. We learned a lot in terms of ways to make it better. The only meal that was rated tasty to very tasty was the meatless meal, which is really interesting. One of the things that was surprising is that the 2 salmon meals were rated unpleasant to okay. And we surmise that this might relate to the fact that salmon is, fresh caught salmon is very common in Idaho, and the flash frozen salmon was probably not up to the quality that participants were used to. The meals are rated well in terms of fullness and being able to be incorporated into the routine life of the participants, adaptability and socialization. They were a little more challenging, but overall acceptability and palatability was okay. And then the qualitative findings, we did online focus groups. The analysis of this data is still in process, but looking at it from what we know as of now, it did appear that the diet lessened symptoms and improved quality of life for some participants, but not for all. Based on the initial findings of the focus group, newly diagnosed patients may have found it more beneficial. And for some, it actually served more as an elimination diet than really an anti-inflammatory diet. So they were restricting a lot of what they normally would eat and learning when they went back to the control diet, they started to learn, oh, this is a trigger food for me. This is one that I need to restrict. And also, I thought it was interesting that some do continue to follow the diet. They noted that they have the patient education materials on the refrigerator and they're following the pattern provided. The delivery of the prepared therapeutic diet was a facilitator for this protocol. It provided a level of control that you typically are not able to achieve when you're doing a nutrition intervention with a community dwelling population. It allowed for predetermined portion sizes. There was ease of prep, which helped increase compliance. And it also taught participants about optimal portions of the macronutrients. The utilization of dietitians was also advantageous. We're trained in both clinical care as well as program management. So that really helped to provide a level of rigor in terms of the study management. And the patient education tools were a plus. We did have many challenges, and I did not list COVID, but that was a challenge, I think, for everyone in this cohort. But with regards to the prepared meals, we had some challenges where participants were traveling and we had to work with the vendor to send the meals to different sites. So this resulted in some unexpected expenses. There was also a unanimous concern over the quality of the frozen vegetables, that they were too mushy. The 1 week cycle menu that we used didn't really mirror the dietary diversity of the community dwelling population. So going forward, I would say at least a 2 week, if not a 3 week menu, it is more the norm for community dwelling individuals. We had the mishaps with the lab vendor. And as I noted, we didn't have these significant differences in the anti-inflammatory micronutrients that we were hoping for. And this could really relate to an insufficient washout period. Since we had to really condense the length of the study, we reduced the time that folks were on the therapeutic diet to 10 weeks, and the washout was only 2 weeks. And this might not have been adequate time to see the changes in the impact of diet on inflammatory markers. So in conclusion, the dietary protocol for managing IC symptoms appears promising. Of course, a larger sample with adequate statistical power is required to really evaluate the efficacy of an anti-inflammatory diet for this population. We had some quantitative findings that were significant. We had qualitative findings that suggest that many of the participants found the protocol helpful. The pilot study yielded insights on protocol enhancements, a 2 to 3 week cycle menu that offers more variety would be optimal. The need to provide a better quality of vegetables and frozen meals, the increased length of both the intervention and the washout period to optimize measures of change, and a more reliable lab vendor are ways that we need to enhance the protocol. Thank you.
Okay, so that leaves us with a few minutes for Q&A, but we don't have somebody to answer the questions. Got a couple of ideas. So Sabina offered the idea that if anyone has specific questions to that presentation, please put your questions in the chat. And we'll get those questions to Barbara and maybe connect the two of you if there's reason to follow up on a discussion. So that's one option. A second option is to maybe hear from some of our biostatistical support folks from the Bird Corps, since this is one of probably many projects that were impacted by the pandemic. I wonder if there are general thoughts from the people can share about, I don't know, cautions in generalizing findings when the sample size is much lower than planned a priori, or if there are any concerns or discussion points around that issue. That may be too generic of a question. Laura, are you offering to suggest something here?
I don't completely get the question. I mean, it's a pilot study, so it's the best you have, right? So not saying that I recommend a pandemic strikes you in the center of your study on a regular basis, but you know, it's what you've got.
Sure, it's what you've got. I guess I'm wondering if maybe there's some sort of selection bias at play here when. Yeah, so given that it is what you have, what would be some approaches people could take?
To do what?
Well, I don't know, do your magic, Laura, like come up with a solution.
Well, so I answer this just like every other statistician. It depends on what you want to do. You know, if you're looking to calculate sample sizes, you probably have something to start with, maybe sort of. But yeah, you have an inherent bias and you can't materialize non-bias out of that. So we learn what we learn. We have good, solid, you know, even if the numbers and the data itself isn't good, there's a lot of good stuff coming out of study design, study planning. This worked, this didn't work. These are the things we need to keep in mind. This is how long things take. This is how much things cost. There's a lot of elements that you gain by doing this anyway, besides extrapolatable, is that a word, data? And I mean, and to an extent, even your sample size calculations, if you can assume that, I don't know, maybe you can make some guesses about the bias, but no, I mean, you're kind of host, you know, pandemics really mess up things.
All right, thanks, Laura. And thanks for
I was
bringing
just
us.
gonna add,
I
mean, you could do a power analysis after the fact based on the sample size that you got, and it will obviously decrease the power if your sample size is less than you had planned. But I think also in planning a study during a pandemic, we have to make some assumptions about how the smaller sample would be to begin with, how that's going to affect the sample. And maybe since we're almost 2 years into a pandemic in the US here, maybe we have a better idea of how that's going to affect the sample going forward, at least while we're in this mess.
Great, thanks, Annie. I know others
To your
have.
point about the bias, Curtis, there's the bias.
Yeah, fair enough. So Laura, and it looked like Jacques was going to say something, but if I could, Jacques, maybe you could say it in the chat, because I opened up a can of worms here and I feel like I'm at risk of getting us off time. So I'm going to move on to the next presentation. And that's Katie Ozawi, sorry. Katie, if you could pull up your slides if you're ready for that.
Okay, can you see it?
Not yet. Yep, we can see it now. So Katie, Dr. Ozawi is from New Mexico State University, and she'll be talking about water insecurity and neglected. It's a social determinant of non-communicable disease risk. Thanks, Katie.
Hi there. Thank you for having us. And I just want to say that I appreciated this opportunity greatly. I started at NMSU, came here from Cleveland in 2019 and immediately applied for this so that I could start working in the local community. And this project has enabled training of a graduate student as well as an undergraduate student who's from Mexico City, and she just graduated and she's going to rule the world. So it's been a really great opportunity for a lot of people in our department to be a part of this. So I'm presenting on this broad topic of water insecurity, which I call a neglected social determinant of non-communicable chronic disease risk. And my co-authors here are Haley Taylor, who's my graduate student, Andrea Maranon Laguna, who is our undergraduate, and then Claudia Mares, who's at the Doña Ana County Department of Health and Human Services, without whom this project, wouldn't have gone forward the way that it did. So my title of this talk is a little bit broad, but I am focusing in particularly on diabetes and obesity in this presentation as the non-communicable diseases of interest. And so I think most of us are familiar with type 2 diabetes as a national and a global challenge. And so within the US, 34 million Americans have diabetes, 88 million have prediabetes. 90% of those with diabetes have type 2 diabetes, and it's the 7th leading cause of death in the US. So despite significant funding investment and a lot of focus on health behaviors, prevalence continues to rise and is anticipated to continue to rise. And I'm particularly interested here in rural Americans who are at higher risk than their urban counterparts. And I also haven't seen declines in diabetes mortality that we often observe in urban areas. Coupled with that, rural Americans are also more likely to be obese and to report health behaviors that promote insulin resistance that can lead to type 2 diabetes. So this crisis in rural America really can't be reversed without removing barriers to healthy lifestyles. And in particular, I'm focusing in here on improving household access to affordable, adequate, and safe water supply. So household water insecurity, this is an area of growing interest within my field in biological anthropology, and I think in other fields as well. This idea of it as a social determinant of health comes from the fact that water intersects with all aspects of our lives. So here I'm referring to the inability of individuals and households to access and benefit from adequate and safe water in their household. And so we know from research across many fields that household water insecurity interacts with and exacerbates other hardships in households, including impacts on household budgets, time allocation, food insecurity, as well as, as well as distress. I'm trying to remove the Zoom window so I can see that. So we know that it exacerbates these other hardships in households, and that it's emerging research is showing that it's a significant determinant on its own. Part of the reason that I refer to water insecurity as neglected is because I think in the US, we sort of have a perception of, we have a water supply that reaches the majority of our citizens. And, despite, what's happening in Flint, Michigan, most people can rely on the water that comes out of their tap. But we do know that water insecurity does exist in the global north as well as in the US. And so based on a 2012 estimate, 1.5 million people live without complete plumbing. And this doesn't include the people who are impacted by things like agricultural runoff, people who live in sites where they may be impacted by other pollutants, et cetera. And when we talk about who's at risk, this tends to be rural as well as low-income communities. And so I think it's important to note that just because we have existing water services in communities, this doesn't mean that it's affordable and clean water for those communities. And we are familiar with the acute effects of unsafe water. There's a lot on waterborne diseases, for example, and I think that's what comes to people's mind when you talk about unsafe water. But we're really trying to understand water insecurity as a part of a human experience. Water relates to your food, it relates to your hygiene practices, it relates to how you manage your household budget, and so your overall stress level. So this really more of a complete picture of what water security means in a country like the United States and in particular areas. Now, how does this connect to non-communicable chronic disease risk? Various studies have linked household water insecurity to hypertension, psychological distress. There's a recent paper that links it to physiological stress as measured by hair cortisol, and food insecurity across multiple contexts. And a lot of this research has been done in low and middle income countries and less so in countries like the US. The relationship between household water insecurity and obesity and diabetes risk hasn't been evaluated, at least published that I've seen before. And I can see several pathways that would link water insecurity to NCD risk. And these are through things like impacting food insecurity. If you're prioritizing your budget to buying bottled water, safe water, over purchasing more diverse foods, that could impact your dietary quality. If you have a kitchen garden, if you cook at home and you don't want to use your water to boil your food, that could also impact your dietary quality. You might also reduce your daily water intake because of the unsafe or unpalatable water in your home, which could contribute to chronic dehydration, which through various pathways could also contribute to hyperglycemia. And then also through elevated psychological distress. Hygiene is a major player here. The study didn't focus on children, but that might be something worth future research in children and adolescents related to washing clothes and maintaining hygiene and stress in school, but also among adults. But dealing with household water insecurity beyond hygiene, as well as issues like affordability, can contribute to this elevated distress, which could also contribute to chronic physiological stress, which can also alter glucose homeostasis. So I think there are a lot of pathways here of potential to link household water insecurity to diabetes risk, as well as obesity risk and risk of other NCDs. So this study was conducted in Doña Ana County, New Mexico, among residents of Colonias, and I'll talk more about our county in particular in a few slides. So colonias, for those who are not familiar, are defined by the U.S. Department of Housing and Urban Development as rural communities within the U.S.-Mexico border region that lack adequate water, sewer, or decent housing, or a combination of all three. And this is, you know, there's more to play here in terms of access to services, paved roads, which also make these communities hard to reach for these kinds of studies. There have been some studies along the New Mexico-Texas border region among Colonia residents looking at water security. And this research has shown that there is a lot of variation in water resources. Some people are on municipal services, some people are not. There's varying quality in the municipal versus well, depending on where you're getting your water, as well as household strategies and what people can afford or not afford to do to treat their water. There are generally reported high levels of dissatisfaction with household water. And in this survey in particular, we had a lot of people writing in that their water was impalatable, the color was off-putting. So, you know, we mirrored some of these observations from other studies, such as by Wendy Jepson in Texas. These studies have also reported generally low levels of water security among colonias, some of the assumption has been that things like low income, Hispanic, Latinx identity would be primary predictors of water insecurity. But what has emerged is that immigration status is a particularly powerful predictor of water insecurity status. And this has been neglected in terms of thinking about it as a social determinant of health beyond, I think, these more acute impacts of waterborne diseases, pollutants, et cetera, because again, we sort of underestimate the extent of household water insecurity, and we haven't really measured it. In Doña Ana County in particular, we deal with particular issues with, depending on the colonia, they may be dealing with a local water board, they may be dealing with wells, they may be going to vending machines for water, and we also have to contend with issues like flooding. We had a major flood amid the pandemic at the end of last year that impacted people's water supply. We also contend with agricultural runoff. So there's a lot at play here in terms of people's household water supply. So my general question, knowing that, you know, household water insecurity is something that exists in this region, how does this contribute to diabetes and obesity risk in these communities? And this was a pretty broad study that was designed to probe different pathways for future investigation. And so I'm going to talk specifically here about food insecurity, beverage patterns, and psychological distress, but these were among kind of a broad range of experiences that were probed in the survey. So as I mentioned, our setting is Doña Ana County, New Mexico. And so I don't know if you can see my arrow moving, but here in South Central New Mexico, in Doña Ana County, we have 37 colonia communities. In Doña Ana County, we have a prevalence of diabetes of over 12% of the population. And my pre-COVID plan was to do in-person data collection, so in-person surveys and biomarker collections at community centers. And so that's one of the strengths of our county, is that we have is really excellent community centers within these communities, administered by the Department of Human Services, or Health and Human Services. And unfortunately, everything shut down, as it did for many of us. So the revised approach was to distribute paper surveys and announcements for the survey at local food distributions via a local food pantry called Casa de Peregrinos. I also sent postcards to a random selection of addresses that I purchased from a sampling frame. And the idea here was to target census tracts with a higher prevalence of incomplete plumbing, so that we could try to get some variation in experiences with household water. People could complete the survey online via RedCap. They could mail back a paper survey. We provided a stamped envelope, or complete it over the phone. And we could complete it in Spanish or in English. And people were compensated $15 for completing the survey. And then they could also elect to be mailed a biomarker collection box, and they were compensated $25 for returning the collection box. So, you know, there's challenges with the pandemic, but this was also an opportunity to test remote collection of biomarkers. Okay, so we had 220 people respond to the survey using this variety of means. And the survey, again, was this kind of a broad probing of different conditions that might be associated with as pathways between water insecurity and diabetes and obesity risk. So these included demographics, medical histories, a 24-hour dietary recall, the beverage intake questionnaire, Cohen's perceived stress scale, USDA short form food insecurity module. And then I also assessed household water insecurity or household water situation in a couple of ways. Had a simple question on the overall household water situation, which is what I'm primarily going to talk about today. And then I also used the 4-item HY short form. So this is the a shortened version of the 12-item household water insecurity experiences scale, which was developed in, I think it's 23 or 28 different sites across low and middle income countries. And it's been validated as a means to assess water insecurity in these settings. We unfortunately don't have a cross-cultural scale for situations like the US. So this was something to allow me to have some comparison with other studies. And I also had additional questions about water situation and how it might interact, particularly with people's livelihoods here within the county.
About 1 minute, Katie.
Okay, sorry. So biomarkers, I'm not going to talk about a lot. If you would like to email me, I can talk about how this went. And I don't have these analyses in yet. Okay, so preliminary results. In terms of issues with water quality and quantity, over 20% of the participants reported issues, and especially with water quality. In terms of our odds ratios of living in a household with poor water quality or quantity, the most kind of salient predictor was household size. You had with each additional person living in your household, you have increased odds of this being a situation with poor water quality or quantity. We also have, suggestions of an association with age and years of residence in the United States. This is consistent with kind of this idea of immigration status, but these are hard to unlink. In terms of NCD risk, I didn't find any significant associations with doctor-diagnosed NCDs, although I just want to point out we had a pretty high prevalence of type 2 diabetes and prediabetes in the sample. And then in terms of investigating these different pathways, I didn't find an association with perceived distress, did find an association with the type of water people were consuming on a daily basis, as would be expected, although I didn't find any associations with swing drink consumption. And I did find a positive association with food insecurity. And I think it's really important to point out that this is controlling for poverty status, because both food insecurity and water insecurity could be an outcome. And so by controlling for that, it suggests that there's a unique relationship there. So we're continuing analysis of this database. My graduate student, Haley, is going to conduct semi-structured interviews with participants from the households with poor water situations to try to further probe this link with food insecurity. And then concluding here, again, we had a large proportion of our sample. This is not representative of the colonias at large, but of our sample, 20% reported issues with water quality. We found this association with food insecurity and consumption of bottled water, and maybe there's something there with household budget allocations, which Haley will probe. No relationships with NCD risk in this sample, but we can't rule that out because maybe a longitudinal study would be more informative. And I think that it's really important that future assessments of food insecurity in these communities would include assessments of water insecurity, because they're both, can be related to health outcomes. And I did find that this remote collection of biomarkers was feasible within this population. So I'm happy to take questions if we have time, or I can address them in the chat. So thank you very much.
Great. Thanks, Katie. You did spark a side conversation amongst a couple of our participants about environmental toxins in water and possibly epigenetics and other risk factors. So I'll let those individuals follow up directly with you. Other than that topic, is there one question, quick question that, that Katie could help us answer? Sounds like you've got a fascinating amount of data that you're still sifting through, and really promising research. So congratulations on being able to collect such a large survey sample, given the circumstances.
Yeah, thank you. It was a great response. And I hope that we can go back and utilize these community centers, because I think we did miss some segments of the population who I know we could reach through those centers, but I think it was a good outcome. Yeah. Thank you.
Yeah, thanks, Katie. So we're gonna take a 5-minute break now, and when we come back, Scott Seville is going to be moderating our next session. So please go stretch your legs, use the restroom, whatever you need to do, and we'll be back promptly at what? It's 2 o'clock, Scott? Is that? Did I get us off track?
Yep,
Okay.
2 o'clock Pacific time.
Yeah, thank you. Pacific time.
Pacific time.
Right, thanks.
We'll get this show on the road. Dr. C, are we ready to go, or do you have any announcements?
We're ready to go, yeah.
Okay, all right, we'll go ahead and proceed with the next session. And our first speaker is Yumi Tran from the University of Nevada at Las Vegas. She's going to speak on mobile intervention in college students with elevated blood pressure. Dr. Tran.
Thank you. I'm going to share my screen. Can everybody see okay?
Yeah.
Perfect.
Yes.
Thank you. So my name is Dr. Yumi Tran, and I'm from UNLV, the School of Nursing. Thank you for having me. And my research is entitled Mobile Intervention in College Students with Elevated Blood Pressure, a pilot study. For disclosure, I report no conflicts of interest. These are my objectives. Basically, I will discuss the mobile intervention and there is any significant impact with blood pressure along with sodium intake in college students who are involved in the mobile intervention. Just a brief background on my populations. Cardiovascular disease is the leading cause of death in both men and women, and hypertension is one of the main major risk factor of cardiovascular disease, and it has been steadily increasing in the 1990s and since 2015. There is a growing pattern of hypertension among young adults, and it starts as early as childhood now. And obesity and weight is one of the issues that kind of associated with hypertension as well. For the age-adjusted prevalence of hypertension among adults 20 years and older, it's estimated about 46% have hypertension between 2013 and 2016. While it is often a risk factor that we associate and know related to cardiovascular disease, and we recognize in middle age and older adults, we are overlooking in the young populations. So targeting young adults of college students is particularly significant, as many of the risk factors for high blood pressure commonly start during this period of time. Studies have shown that the transition to university is often associated with poor dietary choices, such as reduction in fruit and vegetable consumption, increase in sugary beverages and drinks, high fat and high sodium food consumption, especially cafeteria food. On average, college students will gain about 6 pounds over the course of 4 years education. We all probably heard about the freshman 15, and that's very prevalent till today. Additionally, there's activities that college students adopt that put them at increased risk, such as binge drinking, smoking, and as well as stress with being a college student. So therefore, the purpose of this study was to implement a mHealth. It's a mHealth intervention. I call it the optimized blood pressure improvement and abbreviate mobile intervention in college student ages between 18 to 29 with elevated blood pressure, as well as to test is visibility and impact on blood pressure reduction as the primary outcome, along with sodium intake and hypertension knowledge improvement as secondary outcomes after 28 days. Overall, the long term is pretty much pilot this study intervention to increase awareness of elevated blood pressure in college students, and hopefully be able to conduct in a larger sample study and more universities. The method I used was a randomized controlled trial 2-arm intervention, a control and an intervention group, and we recruited at a large urban university. In this case, at UNLV, it's one of the most diverse universities. For the inclusion criteria, I basically recruit full-time college students, ages between 18 to 29, with high blood pressure or elevated blood pressure, between 120 to 139 systolic and 80 to 90 for diastolic. Because this intervention involves mobile and smartphone, the criteria is also to have a regular access to a mobile smartphone with unlimited text messaging, which has not been an issue because everybody have a smartphone now. I didn't encounter any issues with that. For exclusion criteria, we exclude those who take antihypertensive medications because they're already being treated. If they're pregnant, lactating, or planning to become pregnant, and if they have a life-threatening illness or condition associated with hypertension. Before we start the intervention, we conducted a formative phase. This phase is to basically prepare and make sure that our delivery of the intervention met the acceptability, engagement, and feasibility piece. So what we did was we did a 2 focus group, 10 students, 5 each group between ages of 18 to 29, and they participate in a Zoom meeting. Initially, we, of course, pre-pandemic would be in person, but we conduct this during the peak of the pandemic. So it was a 30-minute Zoom meeting, first 5 students for the first focus group. We developed a list of intervention from low, moderate, and high. And so we asked the 5 subjects to rate these text message delivery to see if it's feasible, is it engaging, is it feasible, or overall, was it a good a text message to encourage lifestyle changes in subjects. And after that results, we edit the text message accordingly with the 3 categories. And then we deliver it with the second focus group. And after that, we modify, and then we have a finalized versions of our intervention to start our intervention. For other measure, we also measure blood pressure levels, doing screening at least 2 before we can say that they have high blood pressure, and then pre and post as well. We also did self-reported height and weight, social demographics, and health history, such as their family history, smoking status, what they consume, and so forth. We also administer the knowledge questionnaire, the hypertension knowledge questionnaire, HKLS, and the 24-hour dietary recall pre and post. So for the intervention group, what they have to do was after enrollment and recruitment, they're scheduled for educational sections and a baseline measurements. And we take their blood pressure there as well. And we did baseline measurement before we move on to the educational sections. And we also give each participant a blood pressure cuff. It's a wireless blood pressure cuff that's FDA approved, and instructs them to use it for 28 days. And we show them how to do it, log on, download the app, and so forth. And then they return the demonstration, so that way we know they know how to use it. It's pretty basic and self-explanatory, but we want to make sure that they know how to use it. And then they are instructed to set their blood pressure value to my research assistant daily with a motivational level, 1 being low, 3 being moderate, and 5 being high. We're working on the conceptual model of motivation because we all know that we feel different every day. Not every day do we feel super motivated, and there are days that we feel more motivated than others. So this premises is that we tailor the message according to their motivation. So if they're at a low motivation for the day, the message is low effort. Therefore, it increases their chance of completing the task, versus an individual that are highly motivated, where they're super excited, they have a high blood pressure, they want to do something about it. Then their text messages correspond to their energy and motivational level. And so that's how the message and the level of intervention was delivered. And we deliver it based on, once we receive their motivational level, we randomize and generate the appropriate message. The idea is though that way we don't repeat the message. We have at least minimum 28 messages per category, 28 for low, 28 for moderate, and 28 for high, some more than that as well. And if there is repeat, there shouldn't repeat more than 2 times. This is to help with engagement. And then we also encourage the participant to record their blood pressure daily and send it and communicate that with us, motivational level, and the tasks that we sent them, and whether they complete that or not on a daily journal. This is to help with their self-reflection, especially when it comes to lifestyle, to know why you didn't do something or why you did something. Sometimes help individuals understand themselves better. And after 28 days of doing this, we schedule them to come back for both post-assessment. For the control group, they basically complete the enrollment and recruitment enrollment, and then the educational sections where we deliver the educational information on hypertension as well, so that they have that information and knowledge. And then after 28 days, they're scheduled to come back and basically do the post-assessment. They complete all the measurements. The only difference is that there's no blood pressure daily monitoring, and we don't communicate with them daily. So this is our results. This is the baseline comparison characteristic for the intervention and the control group. A total of 29 participants enrolled in our randomized control trial. The average age was between about 24 years old for the intervention group and 21 years old for the control group. We did not observe any significant difference in the above characteristics. However, the intervention group has a significant higher percent of participants at the graduate educational level, 60% of them, and lower undergrad educational level compared to the control group. This is the other results. We basically put all the other measure in this table. It's a comparison of pre and post clinical data for the intervention and the group. Basically, we found a significant decrease in blood pressure in the intervention group. while there's no significant differences was found in the control group. As you can see, the pre of here, I'm not sure if you can see my arrow, but if you look at under the blood pressure, about 40 subjects have elevated blood pressure, 40 have hypertension stage 1, and 20 have hypertension stage 2. But post, there were 66.7% in their normal range. And there's only 6.7 in the elevated, 20 in the stage 1, and 6.7 in stage 2. So you can notice there is a significant differences in their blood pressure reductions versus the control. You can see there's changes, but there's no statistical significances found. For the secondary outcome, using the ASA 24-hour dietary assessment to extract out the sodium intake, unfortunately, we didn't find any statistical differences in the sodium intake for both groups. And as for the knowledge, the hypertension knowledge, the mean hypertension knowledge score increased in both groups. However, the improvement was only significant for the control group, which was very interesting. And one could explain it because with the control group, we basically give them the educational piece and tell them to be on their own, as if they go and see a healthcare provider, they know they have high blood pressure, the healthcare provider tell them to go and make their lifestyle changes and come back and reevaluate. So in a way, they have to go and seek additional knowledge if they need it, versus the intervention group, we're there with them and they're following our regimen. So that could be one of the explanations. However, even though there's no significant differences, improvement in the knowledge with the intervention group, another explanation could be their sample size. There's only 29 subjects, 15 in the intervention group. So a larger sample size could provide additional power to understand this relationship. So for limitations, we only collected the 24-hour dietary recall pre and post, which may not be sufficient to examine changes in eating patterns, such as sodium, because dietary change on a daily basis, what we consume and so forth. But for this population, it's feasible rather than burdening them with daily blood pressure and then daily log in of their dietary. Also, we did not monitor their physical activities, and it may be the factor that affect blood pressure reduction in the intervention group. We don't know, but we can't generalize because we didn't collect this data. The intervention was short in duration and the sample size was small. However, this was a pilot and our purpose was met to see if this was feasible, engaging, and does it impact blood pressure reduction. And we also didn't examine the impact of sustained impact. But for our R01 proposal, we address all these limitations and improve our pilot, which the purpose of the pilot was to help us with that development. So in conclusion, the M Mobile Health is feasible and effective in this population. It's the first randomized controlled trial to evaluate the feasibility of reducing blood pressure in college students. It does draw attention to the importance of engaging college students with elevated blood pressure and the impact we can have using this intervention. These results provide preliminary data on blood pressure reductions. We do understand it's a small sample size and it's a pilot, but it significantly affects the intervention group and warrant further examinations of this intervention and its long-term effect. And this is my references. Thank you. So I'll stop there if there's anybody have any questions.
I see some questions over in the chat. Evan, I think you have the first one. Would you like to unmute and share?
Yes, thank you for your great presentation. Sounds like you have a really nice study going on here. I wanted to ask you if you guys followed specific protocols to ensure that they were placing the blood pressure cuff in the right location, were their feet on the ground, or their back support, anything specific that you wanted to follow with them on this?
Yes, so doing the education orientation sections, we demonstrate how to properly take their blood pressure and when to do it before eating, caffeine intake, and all of those things. We also give them a one-sheet manual of the instructions as well, just as a friendly reminder. And that's as much as we could do because, of course, they're monitoring on their own. But we give them all the instruction that we could to properly take a proper blood pressure intervention, blood pressure measurement.
Yeah, just to follow up on that. So was there any follow-up to ensure they knew how to do that, or was it just like we show them and then kind of they go on their merry way?
Yes, we did the return demonstration as well.
Okay, perfect. Okay, great.
Yes, and they are in communication daily with our research team.
Thank you.
Thank you.
Dr. Chen, you had a comment. Would you like to share?
Yeah, I just found that really interesting. What you found, the BMI were comparable between the two groups, yet when you looked at the caloric intake, they were really different, both pre and post. And I don't know if you looked at, I know you did analyses pre and post, but then like between groups, was that significantly different? And what are your thoughts about that?
We didn't find significances in terms of that. And the part about the dietary, the pre and post, which I mentioned as a limitation, is when I examined closer, especially the calories, it was all over the place. There was a few subjects that consumed about 500 calories for the 24 hours, even though we instruct them to do the average of their consumption, not just what they have that day. But because this population is college students, their dietary is kind of all over the place, which you can imagine. So there are those that consume 5,000 calories a day, and there are those that consume about 200 or 300, which is mind-boggling. And we're still combing through the dietary pieces. We're just having a hard time trying to balance that out, just because there's such an extreme between those that has such a low calorie intake, and there's those on the other extreme side. But when we run in terms of the weight, there's no differences between the two groups. And we're still combing through the other data. The 24-hour intake, because we use the ASA24 from NIH, they have a lot of information in there, all the mineral vitamins, what they consume for the day. Do they consume it watching TV or electronic? Do they consume it with somebody else? So there's more information there. I'm hoping that we can find more, but we just focus on the three main outcomes, the primary and two secondary, so that we can share it here.
Thank you for that. And just one other thing I wanted to just throw out there for your future research planning is because you're also focusing on sodium intake. And I believe based on just like general population GWAS analysis, only like 2 or 5% of like general population is actually salt sensitive. But I think maybe it's much higher at like 50% or something among those who are hypertensive. So anyway, something that to consider looking at to see if that makes a difference.
Yes, thank you. We want to examine all potential because we know blood pressure, there's so many factors that affect blood pressure. You can take it in the morning and the night it changes. So we're trying to control a lot of that variables. So thank you.
Thank you.
Okay, there's one more question in the chat, but I think if you want to address that through the chat that Curtis posted, and we'll go ahead and keep on the clock. And our next speaker, Dr. Kang, do you have your presentation to put up?
Yes, just 1 second. So can you hear me?
Yes, we can.
Okay.
Okay, and this is predicting an inpatient's risk of benzodiazepine and opioid overdose. Dr. Mingan Kang, University of Nevada, Las Vegas, with Dr. Ji Yu. I hope I got your names right. Please correct me.
Correct. So you can see my screen, right?
Yes.
Okay, thank you. Thank you so much. So let me introduce myself first. So for this presentation, I, Mingan Kang, and the co-PI, Dr. Ji Yu, will present together. So I am the assistant professor in computer science at the UNLV. I joined the UNLV in 2019, and then luckily I got this award for the EHR healthcare system analysis. Actually, my condition is not like 100% the best today because of COVID-19. Please understand, but I'm getting better. And then I think that Dr. Ji Yu will introduce himself.
Hello, my name is Ji Yu. I'm the primary doctor at the UNLV. Also, I'm serving for the substance use, mental health, like uninsured population, and then oversee the federal funded program, the geriatric workforce program, the helping our Nevada establish age-friendly health system and dementia-friendly communities in Nevada. I'm glad to work with Dr. Kang.
Okay, so let me briefly introduce a little bit more about my research before we present this project. So my research interest is focused on some data-driven modeling and some computational predictive system. So we are developing new algorithm to solve some difficult and challenging problem in biomedical field. So we are mainly focused on two problems. One is interpretable deep learning. So what like most deep learning method focus on predicting some, focus on some predictive performance, improving predictive performance, but our interest is how we can obtain some new biomedical knowledge from the model. So that's why we focus on like interpretable deep learning rather than just to predict something. And the another interest is data integration with some heterogeneous data. So there are many types of heterogeneous data in biomedical, for example, EHR and medical image data and some bio data like multiomics, like a gene, protein, something. So we would like to integrate that kind of types of data to improve the predictive performance and then possible so comprehensive analysis. And Dr. Yu?
Yes, the Nevada, there is some health disparity. Since 2015, Nevada remains the #1 highest suicidal rate, especially among the older adults. And since 2019, so our GWEP partners evaluated the AGS, American Geriatric Society, BRS criteria, high risk medication use, coming up year by year. And since 2020, the COVID pandemic triggers a social isolation and difficult access among the adults with chronic joint pain due to like a transport problem and specialty clinic and facility, the shutdown and so on. So basically the primary care, the gateway provider takes more responsibility of preventing the reducing or preventing the drug overdose. It means opioid plus minus benzodiazepine.
Okay, so putting the common interest together, so we propose some developing new deep learning based the computational model that predicts some risk in opioid overdose. So here the motivation is benzodiazepines and commonly prescribed with the opioid for chronic pain. However, the co-prescription cause a lot of side effect. So through the development of deep learning models, so we would like to accurately predict individual risk or benzodiazepines and opioid overdose. So we expect so we can improve some clinical outcomes while we can customize the patient the different factors. So with from using the EHR electronic health record data, so we would like to develop we developed deep learning, interpretable deep learning model, and to predict risk score. Excuse me. Also identify the risk factor. So with this like model, so we would like to reduce the suicide attempt. Also, we'd like to know the clinical mechanism that increase risk scores. So we gather the data. So Dr. Yu will explain how we gather the data.
Yes, the data has 3 steps. First of all, the EHR, electronic health record data collection. We collected the data from the University Medical Center, Southern Nevada. It's called the UMC. The Clark County owned safety net provider hospital. We included about 48 patients with musculoskeletal pain hospitalized from January to December 2018. So we collected the EHR data, demographic, clinical information, and administrative data. Especially we are like an interest in the ICD-10 code, International Classification of Disease, the 10 code, to make sure that the data accuracy and correction. And spinal condition are defined by disc and spinal digit, including status post spinal surgery and spinal procedure using the ICD-10 codes. And after the data extraction using the ICD-10, investigators reviewed the manual chart review carefully. And after this process, the data we collected finally about 300 cases.
Dr. Yu, I think you can continue to explain.
Okay, thank you. So the key covariate, we pick up the length of stay as the efficiency. The drug overdose can prolong the hospital length of stay. And also we pick up the MME, morphine milliequivalent, or DME, diazepam milligram equivalent. It is a standardized like equivalent dose across the type of the benzodiazepine and opioid. And we also pick up the main outcomes, the altered mental status, is the clinical presentation of the drug overdose. We have a GCS, Glasgow Coma Scale 13 and below, and the physician or clinician's documentation, the progress notes, identifying the altered mental status, confused and confusion, and so on. So here is the table, but we use the covariates, age, gender, race, residential, zip code, living status, insurance type. It is more demo and administrative data, and pain, scale, location, mental health condition, substance, functional status. It is more likely the clinical data, and principal diagnosis, hospital stay, length of stay, opioid, MME, the benzodiazepine, DME, and suicide attempts. That is additional key data collections.
Yeah, thank you. So we analyze the data. So data include like around 300 samples of 10 features. Actually, that's a very extremely imbalanced data. So we use some weight to train the model without bias to the majority class, and then we impute the missing value using the KNA imputer, and then also we perform the logistic regression SVM and the neural network with hidden layers or 5 node. So we performed the validation using the leave one out cross validation for evaluation. So this is the result. So here the in this experiment neural network show the best performance. But the sorry. So because the limited sample size, so it's very difficult to say this is a robust result. But this is a kind of some preliminary the result that we can expect from the data. So what we are continuing is, so actually we already developed some interpretable neural network, but so we are waiting for the larger the database that we can get some more robust model for the analysis. So let me introduce interpretable neural network a little bit more, and this challenge and what we did. So most neural network are black box, which is very difficult to interpret, and then to obtain some discovery from the model. So that's why we focus on interpretable neural network. So for the interpretable neural networks, so what we want to do is every single node share some represent some clinical meaning. So that's the model that we'd like to develop. And then the challenge is, actually there are many challenges, but we'd like to address these two mainly. So one is to find some optimal neural network architecture is challenge itself. Because so we'd like to find a certain meaning from each single node, but the neural network architecture is very heuristic, and so there's no like a explicit way to find the optimal neural network architecture. So and then another challenge is so to train the model like robustly. So robust excuse me. So robust training means because neural network involve non-convex problem. So whenever we train the neural network, it produces different final models. So so it may not be easy to say. So we can get exactly same model with from the next training, but we'd like to find some very like a less very varied the model. So with a small list variance. So this is what we worked for the automatically find the neural network architecture. But here, so we focus on unsupervised learning. Most neural network architecture searching algorithms are based on supervised learning. So supervised learning means here's the labeled data is available, but so what we want to do is we find one of some best architecture that represent the data itself without the labels. So this is what we did, and then we got a very competitive like a model with supervised learning, even though we didn't use any supervised data. So this is what we did for finding the optimal architecture for interpretable neural network. And then so another challenge was like a limited EHL data for robust machine learning. So we are in the process to collaborate with HCA or healthcare networks that has access to 4 or 5% hospital admission EHL data. Sorry. So we'd like to train our model using the not only like 300 case, using millions, 100 millions like EHL data. So I think that will be more like reliable, also meaningful models and analysis. And then also we are in the process to purchase national inpatient sample because NIS HCOP data that also include millions of AHL data. So so we are in the process. So once we have access to this HCA healthcare network and NIS HCOP data, we will apply our interpretable neural network to this data, and then we will we have planned to publish the result. So we will build a robust and reliable model for opioid overdose risk prediction using this large EHL data and evaluate the model with clinical samples that we can obtain from the NIHAM patient that Dr. Yu supervised. Using the preliminary data that we propose, present today, so we got some new external grant from the Centers for Medicare and Medicaid Service. So we very appreciate for the grant opportunity. The CMS project will develop another like a deep learning model for opioid risk prediction, but that model will be based on ethnic specific analysis. So we'd like to find some different mechanism based on, depends on the different ethnic groups. So this is our lab that participate the project, and then so we also developing open source software for the every model, so that anyone can utilize our tool for their analysis. And then Dr. Yu.
Yeah, thank you, Dr. Kang. So I can answer the chat box. So Dr. Chen asked about the how the individual level make sure the history or like a length of exposure previous use can be collected. So the current amount the CTR grant has a limited data access. The CMS the grant, we have the individual data. We will have the individual data sampling from the our participant. So there's a two-way. One is the the small sample but more data available individual level, and bigger sample size but a little bit of rough data characteristic. So we try to use the mixed method in the CMS and try to the correlate the individual level and the population level. And Dr. Scott asked the kind of the accuracy of the collecting the altered mental status. So we still has used try to use the delirium or more formal or drug overdose, but formal name. But the reality, the doctor's note or other clinicians note not that great. They usually use the late term altered mental status has been used the most common. So that's why we use the altered mental status is the kind of the pickup. Yeah. So non-lethal opioid. Yeah, exactly, Dr. Scott. Yeah, non-lethal opioid overdose, very hard. So we have to carefully review it's called HPI, history present illness, in the clinician's initial note that has the most meaningful narratives and the context there. Still, there's a challenge to interpret the clinician's note. Exactly, Dr. Scott.
You took on a very hard question, so thank you for that.
Thank you.
Okay. Thank you. We're going to move on to our last talk of the day. And this is Dr. Apoorva Chauhan. I hope I'm getting the name correct.
Yeah, that was correct.
Okay, thank you very much. Okay, the talk is using supervised machine learning to classify participants with prediabetes, diabetes, and diabetes with neuropathy. And there's the presentation, and take it away.
Okay, can you guys see it? Okay.
Yes. Yes.
All right. So hi, my name is Apoorva, and our study focused on using supervised machine learning to classify participants with either prediabetes, diabetes, or diabetes with neuropathy. So the objective of the study was mostly to develop a plantar pressure-based diagnostic tool that can be used to classify if a person has prediabetes, diabetes without neuropathy, or diabetes with neuropathy. the current tests for diagnosing diabetic neuropathy at the moment, they're more like sensory based, where the doctor will like, touch something on the bottom of the patient's foot in order, and then like get their feedback whether or not they feel something or not. And so this is trying to take out that participative nature of it and make it more like data based, so that we can more accurately diagnose diabetic neuropathy. So the plan for our research was to collect the data from a variety of patients participants that are pre-diabetic, diabetic, and diabetic neuropathy. And then we wanted to use machine learning to classify this data and then compare the results from the algorithm with the diagnoses provided by the participants' treating physicians. So like I mentioned earlier, one of the outcomes we hope from this algorithm is that it can reduce that participative component in the diagnostic method, but also to enhance the physician's ability to closely monitor the patient's progression of their diagnoses. So the main instrument used in our study were the Metalogic pressure measuring insoles, which you can see on they're the top picture on the right. So these soles are comprised of a grid of resistive sensors, and they measure a change in electrical resistance that is proportional to the pressure that's applied when the participant begins to walk. And so depending on the size of the insole, so they range from size 35 to 44 in European sizes. So depending on the size, there can be anywhere from 93 to 151 sensors on the insole. And then the bottom picture is kind of what the pressure map looks like, where red is like, if it's more on the red side, then there's less pressure, and if it's like the blue side, then there's more pressure on that sensor. So along with the pressure features that we collected and calculated, we also got the participants' height in centimeters, their mass in kilograms, their age, and then their HbA1c. So in order to better utilize the data, we broke up the foot into 3 different sections: the forefoot, midfoot, and rear foot. And for each of these sections, we calculated 3 different pressure variables. And so these pressure features, the first is the peak plantar pressure, or the PPP, and that's just the highest pressure value in that plantar region during a single step. The next that we calculated is the peak pressure gradient, or PPG. This is the slope of pressures around that peak pressure area, and it's measured according to the 8 neighboring steps. And then we have the pressure time integral, or PTI, and that is the summation of all the plantar pressure values inside that region during the stance time of the step. And then along with these features, we also calculated corresponding asymmetry indices for each of the 3 features in each of the 3 regions. And we calculated that as the absolute value of the difference between the right and left foot divided by the left foot, just because in the analysis itself, we only use the values from the left foot and then the asymmetry indices to show like the symmetry and like the gait of the participant and have that included in the algorithm analysis itself. So the experiment to collect the data comprised of, so the participants were fitted with the insoles on the bottom of their feet, and then they had to walk back and forth between 2 markers at their normal walking speed. And each participant gave between 3 and 5 viable trials, and each trial contained between 3 and 5 steps. Every step from each of these trials was used in my analysis. So this is just an overview of the demographics of our participants. We had a total of 110 participants, 19 of which are pre-diabetic, 62 that are diabetic without neuropathy, and 29 that are diabetic with neuropathy. So a chunk of our data is based off of diabetic patients who don't have neuropathy, but that didn't really play a significant role in the results. So the data itself consists of 1,621 steps, each of which contain the 3 different pressure features, along with their corresponding pressure or asymmetry indices for each of the 3 regions of the foot. And then along with those, those features, we have the corresponding demographic features, so the age, mass, height, and HbA1c for each step that corresponds to that participant. So in total, we had 284 steps from pre-diabetic participants, 911 from diabetic participants, and 426 from diabetic with neuropathy participants. So to do this analysis, we looked at a supervised machine learning algorithm. And these algorithms, they're first trained using a data set that has all of the known classifications for each data point. So after the algorithm is trained, you can use it to test test a test set to classify those data points. And for this study, the algorithm is going to focus on classifying if a patient is pre-diabetic, diabetic, or diabetic with neuropathy. So we used the K nearest neighbors, or the KNN classification. In this algorithm, the K is the number of the neighbors that you want the algorithm to look at. So in this case, our K number was 5. So for each time that the algorithm was trying to determine the classification of a data point, it would look at the 5 nearest neighbors. And what it does is then it calculates the Euclidean distance between the data point in question and then those 5 nearest data points. And based on the mode of the classification of those neighbors, it assigns that classification to the same data point. And so in order to test all the different combinations of our features, we first ran 14 different cases. Each case includes age, mass, and height. And then the 14 cases were just different permutations of the pressure features. And then to test how significant HbA1c was, we would have one case with HbA1c and then the exact same case, but without HbA1c. And then the next 2 slides, I believe, are a breakdown of what each case has in terms of what features they have. And after we ran those first 14 cases, we did a variable sensitivity test in MATLAB as well. And that gave us 5 features that most impacted the results of the algorithm. Those 5 were age, mass, height, HbA1c, and the rear foot pressure time integral. So we ran only these 5 features in an optimized 15th case. And then to keep consistency, we ran it again, but without HbA1c, just to see what the effect of HbA1c was on the algorithm or the results of the algorithm. So we also cross-validated all of the data. So each case was run 20 times, and each time we would hold out 20% of the data randomly to be the test data, and then the remaining 80% was used to train the model. And so all the results that I'll be talking about in the results section, they are the averages of these 20 cases. So this is just a breakdown of what the cases are. And I know it's like a lot, so I'll mention like when I'm talking about the results, what is in each case, but just so you guys can get like an idea of what I mean. Like case 1 has all 3 pressure variables, their corresponding asymmetry indices, and HbA1c, while case 2 is the same thing, just without HbA1c. So then for each of these cases, I just did different permutations of the combinations of the pressure variables. So case 3 only looks at peak plantar pressure and the gradient. Case 5 is the peak plantar pressure and the pressure time integral. Case 7 is the peak pressure gradient and the pressure time integral. And then I looked at each pressure feature individually. So that's what cases 9, 11, and 13 are. And so these were all of our results. Along with getting the average of the 20 iterations, we also got the best case accuracy. So in those 20, what case performed the best? Like, so at its best, this algorithm can give you this much accuracy. And we also looked at the average false negative rate. And this was of participants who had diabetes with neuropathy being misclassified as only diabetic or pre-diabetic. And I'll get into like which cases perform the best in the next slide, but yeah, I'll just go there now. So in our results, we had 9 cases that all had higher accuracy, or accuracies greater than or equal to 95%. And if so looking at these cases 1, 2, 5, 6, and so on, it's all the corresponding cases. So case 1 had all of the variables, and then case 2 was the same without HbA1c. So we can see that like when you have all of these variables, but only take out HbA1c, it doesn't differ or it doesn't harm the results quite so much, except for the very final case, case 16, and in comparison to its counterpart, case 15. So next highest case was case 9, which I believe was just peak plantar pressure. So that one had 91%, and it was the best performing one of the ones that only looked at one pressure feature. And then case 15 had the highest accuracy overall of a 99% on average, and its best case accuracy was 100%, and it has a standard deviation of 0.59% when in its classifying. And then finally, case 16 had a significant drop compared to case 15, being 73%, compared to the other cases where when you took out HbA1c, it really only dropped at about like 1%. So yeah, so all the 9 cases that had accuracies greater than or equal to 95%, they included pressure time, the pressure time interval features, as well as 6 of them included peak plantar pressure features. So what we can get from that is that the peak pressure gradient didn't do much of an effect in terms of increasing the accuracy when classifying, whereas peak or pressure time interval does play a significant role in classifying someone's progression in diabetes. And like, as I mentioned before, there was only a 1% decrease when HbA1c was removed. However, in the optimized cases, removing HbA1c had a 26% drop in accuracy, which is interesting since HbA1c is generally lower for diabetics with neuropathy than diabetics without neuropathy. And it's also interesting because generally, even like HbA1c doesn't always correspond to someone's direct diagnosis because the patient might have it like under control, or like medically under control and like based on their diet and the like, but it was still a significant indicator of where like what kind of diabetes or prediabetes they had. And then so these results indicate mostly that a combination of multiple pressure time interval features, rather than just a single plantar pressure variable in a region, can give an accurate classification most of the time, even when HbA1c isn't known. But if HbA1c is known, then you only really need the rear foot pressure time interval to be able to give a 99% accurate classification. So this research shows that MATLAB can be used to classify the progression of diabetes based on a combination of plantar pressure variables at different regions of a foot, along with demographic data such as the age, mass, height, and the HbA1c. And it also shows that a limited set of pressure variables can be useful in classifying as long as HbA1c is known. And then the low false negative rates also indicate that the algorithm is tuned to prevent the misdiagnosing of neuropathic patients. And so this algorithm would be, I mean, with further testing, but hopefully be useful in a real world application. And the research for further work, we can include the weight and age match of healthy participants just to give a fuller like picture to the algorithm itself. But yes, that is my presentation.
Okay. Do we have any questions out there? Any? I don't see any in the chat at the moment.
Thank you for the presentations. Before we close this meeting, I'd like to introduce our new external advisory committee member, Dr. William Scott. Bill Scott, can you raise your hand? Yeah, okay. Dr. Scott is our new EAC member. He's a professor of human genetics and neurology and public health at University of Miami Miller School of Medicine. And he's also the executive director of the University of Miami Brain Endowment Bank. It's one of the 6 NI-supported center in the NeuroBiobank network. So Dr. Scott is a genetic epidemiologist, and his research focuses more on gene and environment interaction and how it influences the risk of various complex diseases. And maybe we can ask him to say a few more words about his research. And I think one of the slides I saw from Dr. Kang's about dementia and something like that. So that could be related to Dr. Scott's brain endowment bank. Dr. Scott, want to say something? Bill?
I just thank you for the invitation. These were really interesting presentations, and I'm enjoying getting to know what kinds of work that you're doing as part of this consortium effort. One of the other things I do is I'm part of a center that's a collaboration of University of Miami, Vanderbilt University, and Meharry College of Medicine in Nashville, looking at health disparities in precision medicine. And so the focus of many of your projects on health disparities is of interest to me through that as well. So I look forward to hearing more tomorrow, and hopefully I don't ask too many questions that are obvious to people who have been following your work for longer than I have. So thank you for the welcome.
Can you say something more about your brain? And I'm just curious about your brain endowment bank. You know, what was the work of that bank? You know.
Sure, very, very briefly, we're a brain bank that's been in existence since 1986. The endowment part of it is really just to emphasize the fact that when people donate tissue, they're endowing us with a gift that we use, hopefully, to better understand neurologic conditions. And some of the things that you're studying are relevant to the work that we're doing. We distribute tissue worldwide to researchers that are researching neurodegenerative, neurodevelopmental, and neuropsychological conditions. One of the focal points actually is opioid use disorder. Thus my question about how do you identify people with opioid overdoses from medical records, because we struggle with getting documentary evidence on people that donate their brains after they die having struggled with opioid use. And so I know that's a major concern of this group too, and I look forward to hearing more about it. And so as a matter of full disclosure, Dr. C and I go back a bit of a ways to when I was a graduate student at the University of South Carolina, and he was the graduate program director in the Department of Epidemiology. So he and I have known each other longer than either one of us cares to admit, but I am thrilled to get a chance to work with him again.
And I'm glad that when we recruited him, he got accepted both at University of South Carolina and University of North Carolina, Chapel Hill. And we were at that time a very young school of public health. So I told him, come with, join us. And it's a very young school. And I'm glad that he did got his master's and PhD with us. And now I can point to him as one of my students has surpassed the teacher, in terms of his achievement and all the accomplishments he has made in his career. So tenured
not
professor.
Sure how accurate that is, but that's very kind.
Thank you. Okay, I think our meeting is adjourned. If there's no more questions, we can adjourn the meeting. Thank you very much, everybody.